Alrighty. So what we're going to cover this afternoon is difficult debriefing. And we touched on it just a little bit this morning, that there may be emotional issues that come up with debriefing that make it more difficult. And how do you engage the group, or does it take a timeout? So that you need to identify what those emotions are. And then you also want to discuss the options for debriefing with the team. And so that you've kind of set up a plan ahead of time. We've pre-briefed, we have the objectives, we've run the scenario, and then you have a little bit of a plan. So what's going to work with this particular group? With professionals, someone who is a practicing healthcare provider, they have very different needs than what a student will have. And so that you have to move beyond the basics of how well did it go or what could you have done better. And so that you want to build on the knowledge that they have or correct misconceptions. Okay? Sometimes you got somebody who talks all the time. And how do you redirect the conversation from the person who wants to control? Or what happens if you have that very authoritative individual that they are in charge and they're only going to do it their way? And so how do you get the others who feel subordinate to that to be able to express really how they're feeling? Or what happens if you have someone who's shy? And it can be shy, that they really are shy, or it can be that they're afraid, they don't want to look foolish in front of the group, so they've hidden kind of towards the back. And so we're going to use 4 scenarios to identify good and what could be better styles of debriefing. So it's kind of like the good, the bad, and the ugly. And so that I want a little discussion afterwards about what happened in that particular video and what could have been maybe a better way to actually have done it to involve the group and make it a success. Okay? I think we're good. Okay, so scenario 1.
All right, guys, let's talk about how things went in there.
Oh my gosh, I can't believe I forgot to put gloves on before I put in the catheter. Like, if it were a real patient, I never would have done that, but I don't know, it's different with the mannequins.
Tyler putting the NG tube and not sealing up the end, like, oh my goodness, dude.
No, I just was like,
in
the moment, I just was spaced.
I know.
Well, let's bring it back around to what went well. Let's look at the good things.
Well, we had good communication,
Yeah.
you know, for the most part.
Yeah.
Good.
I thought.
And I think once we kind of settled in, at the beginning it was really hectic, and then towards the end we kind of got a little more organized
Right.
and talked to each other more about what we're doing instead of just going in and doing it.
Okay.
Felt like our teamwork really improved.
Yeah.
At first it seemed like we didn't really quite know where we were each supposed to be, and then we settled into our roles.
We
And
were kind of flustered in the beginning, and then kind of.
But we were able to help each other out when we didn't know certain techniques or whatnot.
definitely.
Or to close off the NG too.
All right.
Okay, so as you watch that debriefing, tell me your thoughts about that facilitator.
She let them kind of talk about it, but she didn't really guide it.
Okay, she didn't guide them. What else did she do?
I don't feel like she engaged the one girl. That one girl was very quiet and even very quiet when she did talk, so maybe she would have been a good one to just put on the spot appropriately. Just so what did you think? How do you feel like that?
Anybody else?
She brought them back to the positives.
She did bring them back to the positives, which is a good thing. But from the debriefing, did they focus on, because the students had brought up the air, right? Did she go back and ask for any clarification about the air? Or was it all about, yeah, you did great, you did wonderful, it's fantastic. You know, you had really good teamwork.
There was
But
a lot
you
of,
didn't put
lot
on
of
gloves.
bobbleheads just
Yeah.
doing this, but nobody talked about the error and how maybe, well, what led to that error? Why didn't you use your gloves or whatever else? Why didn't you? How can we improve upon that? They didn't pursue that any further. It was more of a recognition than go right by it.
Absolutely. And so the students, the learners, had already given her the opportunity, the facilitator, to be able to address what they had identified as the error in the beginning, and she glossed right over it. So it's great to give positive feedback, but use the opportunities that you're given. Okay, let's try the second one.
All right, let's talk about the CPR process when that patient started to code. I noticed that, Tyler, you straddled the patient versus getting off to the side. What was your thought process behind that? Because typically you would get on the side of the patient unless for some reason you were running down the hallway on a gurney and you just could not, there was no room on the side.
Yeah. Well, Alex was taking vital signs with one arm, and so he was kind of in the way, and so I really just, like, it was my first thought, instinct. I knew to jump on the bed, but I didn't really know where to put myself, so I kind of, that was my first thought of just straddling him.
Yeah, and in all the training sessions, we've never had him on the bed. They were all on the floor, armless, legless, you know, and it was just so much simpler.
So what would be a way of trying to get to the side of the patient versus straddling? Because is straddling going to be effective for compressions on that patient? Probably not. So how would we work around that so that we could get in the proper position? Any ideas?
Can you just move the arm up, maybe, and
Okay.
and then you get the board underneath when you do that.
Mm-hmm.
Okay.
Could we get a step stool maybe
Oh, that would have been a good idea too.
I think about
as a
that.
thought? Could we maybe push the patient over a little bit so we could get up on the bed if we needed to? Any other ideas on that?
Yeah, it's probably worth the time to move the patient over so that you can
Absolutely.
do proper technique, I guess.
Yeah, that was good.
Hmm?
That was good, I thought.
Okay.
She got set up to talk. We're going to use the error out of the teaching. Yeah. Moment.
So that's good, yeah. Anybody else?
How did they handle that, the student who jumped up and straddled the patient who was doing CPR? I know there's some snickering and stuff going on. Obviously, you think, yeah, that's pretty crazy. But do you think that student felt belittled? Do you think he was treated appropriately about that? Do you think he'd ever do it again? What are your thoughts about that?
I thought she brought it up as a good, I mean, you know, she brought it up as, you know, what was your reasoning for straddling the patient? I know she jumped up to straddle the patient. What was your reasoning behind that instead of you straddling the patient?
Right. And she did qualify it by saying most of the time we stand on the side of the patient and do that. And how about the student's response?
He didn't seem, he'd been, he seemed okay with the correction.
You thought he seemed hurt a little bit?
Or like seemed embarrassed, like, yeah, I really didn't know what to do, you know, like kind of.
He handled it well, but yeah, there's something about that. But she allowed him to say why he did that. Well, you know, you want to keep the arm free so you can have access to IV or something like that. And he did do that, and she did allow that. And even though he may have had some sensation of feeling hurt or not upset, he was able to freely talk about it. And in the end, I think it turned out very reasonable. I don't think she really belittled him. I think she handled that pretty well. And that's just one of many ways that potentially could have gone.
Okay, let's try scenario 3.
Wow, you guys, I can't even believe that. Let's go back to the objectives. Lauren, hypovolemia, isn't that what was going on with that patient? What about that IV rate? How come that didn't get turned up?
I don't know. I mean, you know, I did his vitals and I did his assessment, and there were just so many things going on with that patient that
You should know how to do that, though. That's just part of nursing. That's just part of knowing how to take care of that patient. And Alex, holy cow, blood transfusion. That needed to happen right away. What was going on with that?
Well, there were just so many orders.
That lady was crashing really fast, really fast. That should have been first, getting on that IV fluids. Lauren, tell me about what was going on when you called the doctor with SBAR.
You know, when I called the doctor, I didn't prioritize what I was doing, and
No, you didn't.
And yeah, he, you know, needed more specific information. I didn't have that right away, so he hung up. and I
Yeah,
had to
so
gather it.
does that delay her care?
Yeah.
Yeah, it did. It did. And Alex, you didn't help her get the vital signs?
Well, yeah, and I forgot about that, and so she didn't have all the information she needed. And
I really think you guys are going to have to go back in and do this one again.
What happened? Huh?
Paramedic school, and that's what it looked like to me.
Paramedic school, okay. Accusatory, yeah. And how well do we learn when it's being pounded at us?
There was no teaching there. She said, well, I mean, what is there to learn? There was really, she didn't swing it around and do any teaching. She was just very accusative.
So she brought up the faults and didn't allow the students to explore what had happened. Anybody had, like I said, paramedic school, somebody's had that teacher? All have?
Basically, that's how we're taught to be that aggressive and go get them. And what makes you think you're going to back down like that? You did that when you do it right the next time. Seriously,
I'll agree 100%.
because I don't know how else we can be taught to do what we do, and so we don't want to come back and be like that when we're being. Don't look in your book. This patient's done. Yeah. That's what I'm afraid of. Doing out here, it's like, come on, you guys, you know, we taught you this stuff, why aren't you? So we really got to take a look at how we were taught at 180 on it. So I'm glad I was taught that way, otherwise I'd still be
Milking cows. It goes back a little bit to that graph, that bell curve that we saw about which level of stress do we learn the best under. And so that was very high stress, high stakes at that point, because you don't want to feel stupid. I know that our med students here have come in, and when they've gone into debriefing, that unfortunately there have been others who have said to them, why don't you know that? And they leave feeling completely defeated. Or nursing students, it's the same way. How do you feel if you've been told, oh, you're so dumb, I don't know why you didn't know that. I've told you this 10 times. Does that make you want to learn it better or to do it better the next time?
Yeah, your silos go.
Yep, exactly right. And it's the same kind of thing as we're going into other hospitals and other health organizations and other ambulance crews. Do you think they want to hear all the things they're doing wrong? Is that going to make them perform better? I don't know. I don't think so. So that we have to be cognizant of how we involve the other person, and that we make that the learning about them, not about us. Okay, let's go to the last one.
All right, you guys, let's go ahead and go through the debriefing process. So let's start out with what went well in that particular scenario when you were hanging blood and putting in the Foley and the NG.
I thought everything went well, definitely. I thought we definitely had practiced and knew what we're doing.
And I thought we did good, you know, with like assigning roles to each person and having like the main person kind of telling what to do for each one. And so I thought it went good.
And there's very little repetition. Every time something was done, it was said out loud and everybody knew what was going on.
Great.
Yeah, I guess we kind of just were ready for what we got.
How was the teamwork?
It was really fun working together.
Okay.
Yeah.
Good communication?
Yeah.
I thought so.
Did everybody know what was going on at every particular point in time with that patient?
I think so.
Yeah, for the most part. And we spoke up about our, you know, our tasks and what we did, so I think everyone kind of knew what each person was doing. So
I know when I took vital signs, I was saying them, and I would get over the computer and put it in.
Great.
Okay, just a few comments. You took vital signs, but you didn't actually respond to any of them. So the whole point of this, and if we look at the objectives, is recognizing hypovolemia. What did you think about the blood pressure of 100/48? I was waiting for you to respond to it,
Well, I was working on doing the rest of my assessment first.
Right, yeah, not good enough. And you, as far as responding quickly, communicating and everything, I noticed that you were the one who put the Foley in.
Yeah.
Didn't we teach you something about sterile technique, asepsis, and that sort of thing first semester in our nursing school?
Well, yeah.
What about carrying that forward semester to semester?
I guess it was just kind of really hectic, maybe.
Nursing is hectic.
Yeah.
What about stepping up and ownership of that?
Right.
And you, I saw that you were trying to program the pump. Have a little trouble there?
So what kind of facilitator technique do you think that was? Yes, it was, exactly. And that's one of the things for debriefing you never want to play, is the good cop, bad cop thing. So there was lots that happened here. Tell me some of them.
That first instructor was getting a lot of good communication, but then as soon as it went to that second one, it was a complete flip.
Mm-hmm.
And then I'm sure that's when the communication was. I think they were afraid to answer the question that was proposed to them because they felt like they were going to get, accused.
Mm-hmm. So how do you balance? You have the one who says, "Oh, you did such a good job, everything was wonderful," and then this one says, "But no." How do you balance that?
Praise in public and critique in private. Praise in public and critique in private. Something you guys said.
Maybe. And maybe it is, tell me about the technique for putting in a Foley catheter. Would that have worked maybe a little bit better rather than praising with one hand and slapping them with the other? So that they could actually go kind of through the technique themselves, and so they can say, "Oh my gosh, I did, I touched this all over," or wherever, whatever it is. And so the good cop, bad cop, one of those techniques not to use. And so being consistent is very helpful in debriefing. Where are we now? Okay, so we have difficult scenarios, those that are emotionally draining. What happens with your team if you're out to pick up a 15-year-old who rolled his four-wheeler and now has a blood pressure of 80/40 and a pulse of 30? And pupils are fixed and dilated, and mom and dad are waiting at the ER to learn about their son. Did anybody teach you how to talk to parents? Or is that the doctor's job? Or the young boy, 12-year-old, who's just been raped, and you've been called out to pick him up. What happens if there's such poor team performance that the patient dies or is severely injured as a result of what the team did? How do you address that? Do you let the scenario progress to allow that to happen, or do you stop the scenario partway through?
Earlier they said to stop it where it got to that point, before it got to the end. Stop it at that point and correct it.
Because it's a critical act.
Right, so it's all going to depend on your audience. And what if it's a lesson they have to learn? Ouch. I don't know, there's some disagreement about allowing the mannequin to die, and it's going to be interesting to see what happens. What happens if there's a big disagreement or a fight in the scenario? Do you think it can happen?
Oh, yeah.
Oh, yeah. Happens in the ER, that there's disagreements about what should be done. And can you take a time out, turn the back on the patient and said, we need to resolve this? Tell me what you're thinking. Tell me what you're thinking. How do we arrive at a compromise? And just outright arrogance. I know this is right. This is absolutely what we're going to do, and there isn't any other way around it. We also have difficult debriefings. Go on. Next slide, yep. Oh, one too many. Difficult debriefing, and we've talked about where one person dominates the entire conversation. And it's hard to be able to say, I really appreciate what you have to share. Nicole, can you tell me what you're thinking about the scenario? Yeah. You're thinking about that past scenario that somebody wanted.
Telling a parent that their child died?
Yeah. Yeah.
I always cry every time I do it.
Oh, by the way, is it okay to cry when the simulator dies? Yeah, it is. How about if nobody will talk? And they're like, how do you get them to talk? One of the techniques that we've discovered is to actually use an evaluation tool. So for instance, what you're doing is an MI case, and that you're looking for the steps of appropriate resuscitation. So what you can do is set out the steps, give them a copy, have them watch the debriefing video, and then mark on the sheet which steps were completed in the right order. So now you've given them a tool to be able to have the discussion about in your final debriefing. And so that they actually have been an active participant by they participated to begin with, they have now participated by watching the video, and they have a tool to be able to talk about what had happened. So that's one of those other tricks that you can use.
Another way if people aren't going to talk is to stimulate the conversation by, I'll get my microphone on here, is to stimulate the conversation by saying, it's really quiet. And usually when I have a group that's really quiet, there might be something going on that I'm not aware of. And if it's a medical students, I'll just say, I know it's week 6 of the block, and they have 8-week blocks, and week 9 is all testing. So about week 6, they get high anxiety. And so I'll say, it's week 6. Could it be that it's just a really tough time for you? And Mr. Adams back there, you could tell me in week 6, what are your thoughts are when you're doing something other than studying? Studying. So I can look and say, do you think that could be it? And they'll all go, we just can't get our minds off the Krebs cycle today or something like that. So they want to be studying. And no matter what you do, you're not going to get an in-depth briefing because their minds are elsewhere. Or if you sense that there's been something terrible going on and there's a domineering, angry, and nobody wants to talk, they're all fearful, you can just break the ice and say, well, here's what I noticed. I noticed that maybe there was a little angst between a couple of you and something like that. This is a safe atmosphere. We're not going to carry any grudges out of here, and what stays here, the officer stays here. Remember, can we talk about it? Ask for their permission to be able to talk about it, rather than force them. But by asking their their permission, not too many of them are going to turn you down. So you may get a little bit. But
the other one is to talk about that this may feel like an artificial experience, but what other experiences have you had that's similar to this? Tell me your story. And, you know, we're healthcare providers. We always have stories, right? We could write the book. I work in labor and delivery. Believe me, I could write the book. I had one little gal who was using imaginary things for pain control. And so what she'd said, A was for apple, fruit, bananas, cherries, and so on. And then she was up to pie, so the contraction would come. And she'd go, apple pie, blueberry pie, cherry pie. And then we'd gotten further in the alphabet, and she says, raisin rum pie. Oh my God, I hate raisin rum pie. And then she continued on to the next one. Like I said, we've all got the stories. So sometimes that will break the ice to get the audience more involved. You also have the inability for participants to admit their mistake. Again, I work in labor and delivery. I have this wonderful nurse that I work with that the entire world is black or white. Do you all know that person? Black or white, there's no gray. And so they were over doing shoulder dystocia drills, and the baby was coming. And she said, where's the doctor? I said, well, he's not here. You've got to step in. He's not going to get here in time. And the next words out of her mouth was, well, hold her legs together. It's like, oh my gosh, you've been a nurse for 20-some years. Do you really think that's going to work? But if we would have said it to her, this is what you said, she would have been absolute, I did not. And so using the videotape, being able to go back and to view it, that you can then change that behavior, because now you have the record of what had happened. And so that, so the doctor says you need 22 milligrams of whatever, ephedrine, and what he wanted was 0.2. And so that they don't want to say, well, that's what I really said. It's got to be the nurse's fault. That without beating up the other person, you can say, that in communication, that sometimes we don't hear what you say. Or my mind perceives something different than what your voice said. And so that you can use the debriefing as a chance to show what really happened in the room and what people said and what they heard.
And when that person may continue to just deny what they said before you do the video or fail to admit their error, what you can do is give permission for the other people in the group to talk. Because that person who's going to stick to his guns and not change is going to be intimidating to the other people. The other people know him. He's done this for years. And you know what? If I bring it up, I'm going to suffer for the next month under his hammer. So I'm not bringing anything up. So what you can do is give permission for that. You take the rap. And you just say, I'm going to ask you to share something with me about the situation that you may be scared to, but I need you to do that so we can get past this and make it better. And you might be able to give permission for them to do it. So you take the blame for opening it up, not them. Let that doc be angry at you, but not at his colleague. And that does sometimes work as well, to open it up for them. We've got a video coming up, so before we do the video, is there any people's experiences you have handling that difficult person? Maybe Cheryl didn't talk about, or we didn't bring up that you have tips on handling a difficult person.
I just have one question for you guys, since you do simulation so much. Like, have you ever used SimMan to open that up? Like, have the SimMan talk like, hey, I noticed you started an IV, but you didn't alcohol prep before. Like, I noticed you making them, so the patient's actually saying.
During the scenario.
Or the debriefing. Like, you have that locked up room, the doctor who doesn't ever do anything wrong or whatever. Have the patient do, like, if they're just locked up and you're like, who's going to be the bad guy to get this going, is to have your SimMan say.
So if we're in the debriefing room, we have never done that in the debriefing room, but I think that's a great idea.
Because then nobody gets blamed for seeing.
And then it's, he's kind of talking, giving feedback, and then it can kind of lighten the mood even too. Like, wow, this is
Whoa.
Yeah.
So if you're debriefing in the front end of the truck, and one of you is still in the control room, you can just, you have to communicate well with your crew, or know that you can do it. But if you're sensing that this isn't opening up, I think that's a wonderful idea. It'll be Mediman, not SimMan in the truck, but just have Mediman bring it up and says, well, you guys aren't talking about, let me mention something. As the patient, I noticed, and that makes me feel really uncomfortable. I don't think I want you putting a catheter in. That would be great. So that's a great scenario to use, and we're going to try that sometime.
That is very good.
Any other thoughts about it? I love that. And we have used, during a scenario, the standardized patient that's behind the voice will recognize something going on. And, for example, if the student is listening over the gown, sometimes the standardized patients will just say, hey, you can listen underneath the gown. You can listen under my breast and my heart. I don't mind. No, that's fine. Well, Dr. Allen said that when he listens, you always have to listen under the skin. How come you're not? Sometimes like that would work out as well. So, anybody else? I know you've all had difficult patients or difficult partners. I just talked to a friend who was able, his wife is a nurse, and his wife just started working with the new doc. And the new doc has a personality issue. And she has a very strong personality, but there's nobody who hates her. So this doc was going to do one, I won't even say what he's going to do or give away who it is, but this doc was going to do this procedure and just walked in and told the patient, hold up your arm, and he was going to give some sedative and said, okay, just do this. And she just took her hand and put it in the doctor's hand like this and said, listen, this patient needs to know what's going on. The patient already knows what's going on. You've given them information to them. So, trust me, doc, this patient needs to hear it from you. And she didn't let go of his arm until he made contact to her face. Okay. Mr. Jones, here's what we're going to be doing right now. And he explained it to him. And then the patient said, hey, thanks, doc, go ahead. And then afterwards, he came to her and says, what the hell was that all about? And she said, I know you're new. I've been in this town for 30 years. I know this patient. He's my neighbor. And I also know that when he is around people he's not familiar with, he is scared to death. And you didn't notice it, but he was shaking. He didn't know who you were because you didn't introduce yourself, and he didn't know what that stuff was that you were giving. He thought he was going to die. He goes, oh my God. And she said, just by you talking to him like you did, at the end, it made all the difference in the world. So she said, thanks, doc, I really appreciate it. And here's the doctor. The other nurses just can't work with him because it's more difficult. But this gal talked to him. And now he relies on her, and she can pretty much control what he does when he makes those mistakes. So she has a way. I should probably have her come here and teach us how to do it, but she has a way of working that way. So, well, the next video that we're going to show you is a video that we did with a doc from the family practice residency, a paramedic in town, a nurse from the College of Nursing, and a medical student. The unfortunate thing is they couldn't be here right now. It didn't work out for them to get here. But what we would ideally have liked is to have those four sitting right here. We'd show you the video what happened, and we were going to debrief it right in front of you. A little bit difficult debriefing. But what I'd like to preface it, we'll watch it. And I want you all to watch this from the standpoint of a debrief. Don't evaluate the whole process. Did they get everything right? All this. Look at each person individually and try to sense what might be going on. It's kind of subtle. It's not an overbearing, you don't have a doctor that's throwing charts. You don't have a nurse that refuses to do things. So it's not just a real blatant thing. But watch for the subtleties, and then let's talk about it afterwards. The medical student that was in there is not able to be here because he matched out in Idaho during the recent match, so he's out looking for a home. But we do have a medical student here, Nick Adams, and Nick will help us out, and he can give some information from the medical student standpoint, which is a key person in this video. And Nick's been in many situations and understands lots of medicine. He's one of our top students, so we're very fortunate to get him here. But he can add to it too for us. But watch it from the standpoint of you're going to debrief this thing.
Jim.
Oh, Jim, please.
Okay. All right. We've got people coming in to check on
Hi there,
you.
Jim. I'm Dr. Rude, and this is my crew. We're going to try and fix you up here, okay? What's wrong? Okay, thanks. I'm feeling pretty good right now. Okay, why are you here then? Well, my wife called for the ambulance. I had a bad episode when I was in the garage. Have you been having anxiety? No, I'm retired. I don't have any worries. Oh, okay. So you're having some chest pain, huh? Yeah, right now it's not bad. It's more of a normal round for me. Okay. I'm going to have Justin here to ask you some more questions so we can try and figure out what's going on, okay? Sure. Nice to meet you, Justin. Nice to meet you, Jim. So, how bad is your pain right now? Oh, it's not bad. It's pretty normal for me to have this right now. Okay, so you've had pains like this before? Oh, yeah. My doc gave me some meds for it. He called it GERD or whatever. Okay, and how often do you have problems with your GERD? Oh, gosh, almost every day I have some discomfort from it. And what time of the day do you have the discomfort? It's mostly, say, an hour or 2 hours after I eat. If I eat something, it pretty much goes away. Or if I take... Do you have any problems when you do physical activities? Pardon? Any chest pain when you do physical activity like walk? No, not normally. I go out and golf a couple times a week. Okay. And so the chest pain you had today is a little worse than stuff you've had before? Oh man, not a little worse. It was a lot worse. It just dropped me. Okay, Justin, what do you think we need to do for this guy? What kind of test do you want to work? Should we do some Nitrous? Chest pain's a little worse than it has been, so I'm thinking if I don't think this is GERD, he might have had an incident for possibly a heart attack. What kind of blood test do you want to do on him? That pain's coming up a lot. Yeah, I think we should definitely get cardiac enzymes, maybe PPI. There you go. Probably CBC just to check hemoglobin. Nurse, can you order some labs on him? We want a CBC and a metabolic panel and a troponin and an EKG and a chest x-ray. All right.
Hello, this is ER room 1, and we'd like some stat labs, please. A CBC,
It feels like somebody's sitting on my chest here.
Does
your pain go anywhere?
Thank you.
Can we start him on an nitro drip? We can do that. So when was his last? We haven't given him morphine. Would you like to give him morphine? I think that would. Well, I think that's part of the algorithm. Okay.
Let's put this under him, and then we'll...
Oh man, this is getting worse. Might you do something for me?
Yep.
What's? Oh man.
I know, that's kind of
hard.
hard.
Cold. So you're in charge. How much morphine do you want to give him?
I think I've seen people use before in this situation before.
Sounds good. Can you give him 4 milligrams of morphine?
I'm on my way to get that. And you've got the alcohol.
Oh man, guys. This is really hurting. We're going to give you some medicine to make that better, Jim.
Hold on just a second. Here comes some pain medication.
Oh man, this is like the worst it was in that garage. This is the worst pain I've ever had. Nitro drip is running. Thank you.
Does your pain go anywhere, or is it just in your chest?
Oh no, it goes right up to my left arm and shoulder. It's my neck and jaw. Just sweaty and dizzy, guys.
Yeah. I'm giving you medicine for pain. Are you feeling that?
No, gotcha. We're trying to figure out what's wrong with you. Check his blood pressure. How do we do that? He's in VTAC. Okay, guys, we need to get to work. You want to manage his airway? Okay. Nurse, you want to give him some epinephrine? A milligram, please, IV. And then you need to call the cath lab. You want me to do? You need to manage his airway. Start bagging him.
Alright, I've got Epi here.
And we need to start chest compressions on him as well. I need to ready the cath lab. We've got a patient that's in VTAC and is very unstable. Can you please set that up and call the cardiologist and get him in here? We need to defibrillate him. We need to charge those panels and shock them. Nurse, can you take over CPR while...
Dr. Hartman to the ER, please. Dr. Hartman to the ER.
Thank you. Charged.
Okay.
Everybody clear?
Clear.
Still in VTAC. 360.
We ready?
Nope. Charge. Everybody clear?
Yes. Do I need any of the strips started, sir?
Let's give him another milligram of epinephrine. Oh, hold on. We got a rhythm.
Okay.
Jim, can you hear me?
Jim, are you? Okay, Jim. How are you doing? Yeah, I bet it does. I'm just gonna put your head up.
No, I want to send him to the cath lab. He needs a heart cath. Okay. Jim, you're having a heart attack, so we're going to have to send you over to the cath lab. Okay? You just had an arrhythmia that comes.
A nitro drip or a nitro?
We can start him on heparin.
A heparin?
5,000 unit bolus.
Yes.
And then 1,000 an hour. How you doing? Feeling any better? Better here. That's good.
We're here from the cath lab?
Yep, there you go. We're ready.
Awesome.
He's having an MI, so he needs to meet the cardiologist.
I've got Dr. Hartman
Get
waiting.
moving.
We're going.
We don't have all day.
Open the door.
The video that you saw is the same, that's the video system that we use over here. It'll be very similar to what you'll have on the truck, so you have that capability. We can go over those later, but so let's just talk about it. Nobody had a yelling, screaming, arrogant bastard type of guy there, but how would you describe Dr. Rude in his behavior there? Now you're the debriefer, so we're trying to figure out how are we going to debrief this scenario if he's sitting there. What's Dr. Rude like? What did you think of Dr. Rude?
Kind of seemed like annoyed, like he had somewhere else to be.
He didn't really want to be there.
He was just not into it.
Was he bored, or did he really just not know what to do, so he didn't know how to respond? Or was he got it under control, and he thinks he knows what he's doing? It's kind of hard to tell, but he's not really with it, is he? Not engaged at all, is he?
I mean, he's thinking of it when everything's there. Yeah. Wasn't really, he was just like, well, I guess we should
Exactly. He's kind of got that attitude, well, this is the control, this is the way it's going to go. I've got control, and so what happens, happens, and that's life. You know, that's kind of like an attitude, not quite right. When you're debriefing him, think about that now when he's going to be sitting here and you'd be debriefing somebody like that. He's going to have the same attitude right here. He's going to be sitting in the chair. You can just imagine he'll be sitting like this. What happened, Dr. Ruth? Coded? So what were you feeling? I had an itch back. You know, he's just not, it's not going to be what you want. How was his response to the medical student? A little condescending. Right at the very beginning, it was Justin. So he said, Justin, I want you to take over. He talked to the patients. So we have my medical student, Justin, he's going to take over. He just kind of threw him into it, didn't he? And he didn't give him much. And he had as much knowledge as we had going into it. So Nick, if you were that medical student and you had a physician that just said, Mr. Jones, we're going to take care of this, see what we can do. Nick's my medical student, we'll let him do it. And he just backs off. And he's just kind of standing back there working with you. You know you've got something critical. What's it feel like in a situation like that as a medical student?
Well, I guess this would, when you threw the medical student in there before things were getting very critical, but that's a scenario I've been in multiple times, actually. And you really, you almost have to, maybe in a less critical situation, almost apologize for it. It might be hard to look over your shoulder, but, you know, try, introduce yourself and make that transfer a little less, abrupt or callous on that. At least make it easier for the patient.
So you're recognizing at that point that the attending physician just kind of threw you in, was a little bit brusque and left the patient hanging. So you as a medical student might smooth that over. You know, hi, I'm John Allen. I'm a medical student that works with Dr. Rude, and what we want to do is get history from you, and we'll take care of the best we can. So tell me, Mr. So-and-so, tell me about this discomfort. That's kind of how you would manage it.
Absolutely, yeah. I would try to ease that transfer over a little bit better, and almost try to make up for the lack of bedside manner position.
Now you're hearing that from Nick, and I haven't worked in the clinical with Nick, but I had him in class for a whole year, and I know about his abilities. Nick is exceptional, and he's not paying me to say this, and I'm not firing him up. But Nick is one of the medical students that you want to perform your brain surgery on you. And then you got the medical student over here that really, he might be able to empty the garbage, but you don't want much more than that. But the kind of thing that he thought is you've got to try to smooth over. And you can do that without offending your attending physician too. So then we're going to see the medical student. So how did you see Justin, or the Nick in the video, how did you see him behaving in here? The attending, older?
Very
unsure, kind of quiet, wasn't he? And he was asking questions, but he was kind of quiet and subdued, and
nobody touched him.
Nobody touched him, except for the nurse. And the paramedic.
Yeah. Isn't that something?
Well, what I found interesting is all the hands in the pockets. There's on the patient, both the student and the physician has their hands, whether the student had his hands in his pocket while he was asking these questions.
Exactly. Wouldn't it have been nice if they would have just, this scenario too, would it be nice to say, hello, Mr. Jones, I'm Justin, the medical student. Stick out your hand. Just put your hand on his arm or something like that. Those are the kind of things. It makes a difference. And these guys were prepped for the scenario, so they knew they were acting as if it was real. They were deliberately making mistakes for us to pick out. But yeah, they were disengaged there. How about Sandy, the nurse?
It seemed like anybody knew what to do, but nobody knew their roles.
Nobody knew the rules. The roles. You're exactly exactly right. Sandy, the nurse, was going back and forth trying to get things done. My guess is she knew what needed to be done, but she wasn't hearing it from anybody. So she started to do it and was hoping that the attending, yeah, good idea. Why don't you get that ID going? Why don't you do that?
No blood pressure, he just started nitro.
Yeah, but the student had, she just started, like, she knew what she needed to do, like you said.
So she was trying to take control for the errors, for the misses that were happening. And then Mike, paramedic, he was so worried about that monitor that his focus wasn't anywhere else until Dr. Moon told him to do something. Then he did something. Otherwise, he was kind of a lost buddy there too, wasn't he? And what happened when he came back and he looked at the monitor, you could see him look, and there was arrhythmias. What did he do? Nothing. In reality, he's a little intimidated by Dr. Moon. I'm going to back up the very beginning that Dr. Moon is one of the best docs around here. And originally we told him to be cruel, angry, bossy, and arrogant, and we had to do a number of takes. He said, I can't do that, that's not me. This is as mean as he could get. Dr. Moon is a very, very good doc, and all of them are very good. So we're sitting down in debriefing now. We've got a doc that's disengaged. We've got a paramedic who just, he's worried about the monitor, but is afraid to say anything. He doesn't want to interrupt because that's the doc. You got a medical student who feels a little bit intimidated, told what to do, is a little bit scared, maybe not having done it. And you've got a nurse who knows what needs to be done, and she's so anxious. She's trying to do something. She's feeling a little bit fighty. She wants to do it, but she's also afraid of what the doc is going to say. That's who's sitting here right now. How would you open up this scenario? Give me an opening line. I'm coming in, and we just got sat down. We're going to start it. What should I say at the very beginning?
Well, patient is that.
The patient is that? Yeah. I'll say that one later.
So how did you guys think that this went?
Yeah. So, yeah. How do you guys think this went? Tell me what you saw. Or another thing is, let's just recap what just happened. And nobody answers. So, pick on somebody. If the one that you want to really get to open up first. Yeah, I know I've got to work on that a little bit. And he may be a little bit difficult. So, I'll use it kind of like a teaching scenario. So, Justin, I've got you in class before. I know that you've got a pretty good handle on things. What do you see how did this unfold? Oh, we got in the room and this guy was having chest pain and he started having arrhythmias and scared the crap out of me and, I guess we did okay. And Dr. Rude's just sitting back there, just waiting. He didn't want to say anything. So he tells you that scenario. How do you get them to open up? Everybody else. Let's just talk about some questions we could ask. I wish there were really here that we could do.
I think one of the things when you're starting your debrief, one of the things you need to establish again and recover is what were the objectives of this scenario? What were we trying to do? Because maybe the objective is this was not to cover your code, but it was communication or teamwork or something like that. And so they didn't do CPR right away. But maybe that's not what we're trying to do. What was the objective? What were we trying to do? And then you can,
And their objectives,
what happened.
Their objectives in this were to, when they get done with the scenario, they would be able to identify 5 or whatever key points to team functioning and be able to function as a team, basically. Number 2, identify the critical issues in a patient having coronary ischemia. And number 3, use the treatment, whatever the treatment protocol is for an acute stem. So those are the basic things. So exactly, going right back to the debriefing objectives. The objectives are to be able to work as a team together. So we pull out the objectives. Well, when we came in here today, folks, one of our objectives is to work as a team together. Dr. Rood, as the physician, typically you're thought of as a team director. Did you feel that you were the director? Did you pass that to somebody else? What did you notice, or how did you handle that? I'll give it to Justin. He's a medical student, he's got to learn. We're going to get him going. That might be one response. So going right to the objectives is the way to get somebody to open up. How would you approach Dr. Rood specifically? How would you approach me? I'm Dr. Rood. Knowing that I just sat there and had my hands in my pockets and my arms crossed and was just kind of aloof.
Ask him what he thought the team did well, or put it on him, give him specifically, point him out and say, what were your thoughts?
Dr. Rood, I know you've ran a lot of codes before. Is there anything there you would like to have seen done differently, or that you think went really well with your experience in the past?
Like most codes, you're glad when they're alive, so I think our team did well.
Is there anything you could have done different?
I don't know. Maybe I could have had a nurse that felt a little more comfortable in the room, that maybe had taken care of some cardiac patients before or something. That might have been made it a little easier, getting on quicker that way.
But what do you think you could have done different?
Probably got the medical student involved more and made him do the CPR.
That's not what you did.
Justin, why don't you do the CPR? Why don't you handle the baby? I think that would work because, medical students, they have to get practice on that. And I know that Justin's done babies before, so I probably should have had him do CPR. Yeah, I thought it went pretty well.
Dr. Rood, can you explain your interaction between yourself and your team members in the middle of the code?
Well, I was a team leader, so I just thought, I'm going to let them function, and I'll stop them if there's any gross errors. And, they did pretty well. I had to jump in and order some labs, and I had to tell Justin, what are you going to do now at this point? He was a little slow, but he got it. And so, that's what I had to do. I think it went pretty well.
But how about Justin? Justin, how do you feel? Give him a chance.
Here, Justin. Come on down here, Nick.
I'm being graded.
It's me.
Well, I think it went well. I think there's some things we could have improved on, and some things that I think we did what we should have.
What's something you could have improved on?
Well, I think we could have improved on maybe a little more feedback communication.
What do you mean I didn't talk to you enough? I mean, we've been working together for a week now, and I've pretty much told you what to do, and you did it. I mean, did I do pretty well?
I don't think, Dr. Rood, I think he was probably trying to say that. What was he saying?
I'm trying to say you were delegating. I just mean feedback being our part. Once you delegate, one of us, whoever you were delegated to, could accept that role, accept that task that you were delegating.
Oh, that's good. Yeah, I think you could have done that.
I think we could have done that better. Also, maybe a little bit more specific in the delegation, but I think that was just.
I guess I could have delegated a little better, yeah.
I was Sandy the nurse, but you didn't delegate anything to me. I didn't know what to do. I was just really confused in the room.
Sandy, you haven't done many cardiac cases. I've never seen you in the ER before. I mean,
No.
you're not used to this, so.
No.
No, you haven't yet?
Sandy, what do you think was wrong?
I work inside.
In this code, I know you have a code on here, but what do you feel? What do you feel about
Patient live.
That's good. Right?
Yeah,
But
yeah.
do you think that there's something you could have done
I'm not floating yet.
Did, you know, like working with me or
No, you're fine.
I
I just
Yeah.
feel very comfortable with
Did you get direction, or did you feel you were using ACLS protocols?
AC what? Are there protocols? Really?
And that, you know, that's, I think what we will, but that's what I was saying, I can pretty much tell that you hadn't had much cardiac experience, and that's not your fault, but, you know, that could have been better if they would have sent somebody that knew ACLS, and somebody had something like that, you know, that would have made it better.
But since she didn't know what she was doing, do you think maybe the team could have helped her out a little bit? Maybe some nursing guidance?
I think that's a great idea. This is a teaching experience, and again, you know, Justin's had training. They got CPR and they got ACLS before they went into the clinical. So I guess I could have relied on use this as a great teaching mode. Yeah, that would have been really good.
It could have maybe been a little more instructive. I agree with that. I think.
You know the protocols.
Yeah.
So yeah,
I could have helped her out with those. I was normally what we've done in other situations in other codes is the kind of the leader or whoever is designated as the leader would kind of, if somebody wasn't quite sure or on the same page, they usually fill them in. So usually that's helpful.
We haven't heard much from you, Tom. What do you think?
Mike, I'm Kermit.
Oh,
Mike.
Kermit.
I was just doing my job.
What do you feel like went well? Like, I mean, what did you really like about that?
Well, no, it's not really like, I mean, we saved the patient, the whole job.
Okay, so in relation, you're out in the field, you probably see codes all the time, right? So using what you've done in the field, I mean, how do you feel like this could have went better? I mean, if this was your patient in the middle, and you were the team leader in the middle of a grassy field, some farmer, you know, just collapsed off his tractor, you know, how would you have done it differently? Or is there anything you would have done differently?
Yeah, there's much that would have been done different because it's a different situation there. We're a team that works together.
Okay,
You
so
know, we weren't a team that worked together.
So
You know,
how
this
do-
code just sort of came in and we just happened, you know, to be that crew.
So if you, let's say you were given a brand new EMT you've never worked with before, how would you help that EMT to be successful with you in that code? If that's all you had?
Since I work with EMTs. We only work with paramedics.
Okay, you have a brand new paramedic. So how would you work with that brand new paramedic in order to make sure that you had that kind of an update?
That's a good question. I probably would have had to give a lot more direction. You know,
Well, I'm going to stick up for Mike because I've worked in the ER with him before, and this guy knows his rhythms. He really knows his rhythms, and he watches that monitor like a hawk. So I think he knows what to say. So if he had a new paramedic there, he'd be teaching him the rhythms, I think.
Okay, so as I understand it, you would be communicating with the new paramedic what the rhythm was and telling them what you think they should do. Is that kind of what you're saying?
Yeah, I would be letting know what rhythms are and what should be coming next. The anticipation was just by saying that, because we're a small team, that's, you know, I wouldn't have to say, well, paramedic Tim, you do this. It would be, I need this done next.
So that being said, you feel like your role working with this team was well defined?
For that situation,
What would you have done if it was your dad? What would you have done?
I would have been calling out the orders. I wouldn't have waited.
So what took you so long to step up in the middle of this one? If we take your dad out of the picture now?
That's a good question. I was waiting for, same direction would be the wrong word. If there's a word in there, you're waiting for, to see how I would fit in and what I would do, you know, what the team would be wanting me to do.
So Tom, I want you to ask me, to say, let's move on, let's change directions here. Dr. Ruud, it took 50 seconds to start CPR once you recognized the VTAC. Can you tell me the process that was going on? What were you thinking?
So how would you, if you were to encounter this again with your...
No, I want you to say what I said. I want you to say, Dr. Ruud, I saw that it took about 50 seconds to start CPR. What's your method for getting that started?
Outside of this situation, how do you normally start and initiate CPR? Different or is it different?
You're telling me it took 50 seconds to do CPR? Oh, you look at the video, but was that 50 seconds? I mean, we were on this guy right away, weren't we?
It seems a long time sometimes, it's shorter than others, but we can play the video with
Yeah, I never left us out of bed.
Yeah, we're going to have to look at that because it wasn't 50 seconds. I bet it was 10 seconds, something like that.
Okay, maybe 15.
Should we watch it again?
Shall we do it? Let's watch
We'll watch it again. Look at that. Oh my gosh! Justin, I told you to get on this case. Well, I mean, I'm really sorry. I guess.
Sorry,
No. I know you know this. You're better than that. And Mike, I mean, you were watching. I want to look at the video there, Mike. Come on. I mean, that's maybe it fell apart because of that. I mean, nobody's doing their jobs.
Dr. Ruud, why did you lay your hands on the patient? Why didn't you step in if you saw your team struggling?
Because I'm a team leader, and I'm supposed to stand back and observe and get them involved. That's what happened. But I mean, it looks like maybe I should have taken the bull by the horns, and I didn't do that. So, just maybe I failed you guys. And we were very fortunate the patient survived, but wow, 50 seconds. God, I would have never guessed that. And we have a nurse who doesn't know cardiac stuff. We have a medical student who's green, obviously, and one of our best paramedics that recognize things. But Mike, how come you didn't tell me sooner? I mean, I'm trying to see the whole thing, but I rely on you guys.
It just, you know, it didn't seem like that much time went by.
Had Dr. Ruud not been the leader, who would have taken the lead? Would you have felt comfortable if this was a different scenario without Dr. Ruud in the room?
Yes. Fine, we do it.
Why is that?
If,
Why do you do it that way?
Why do it?
Do we want to get into that?
Yeah.
Wait a minute, we're into this now. I got to find something. Okay?
Okay, I guess I should ask.
Mike, why would you do it if I wasn't there? What?
I guess the bigger deal is that because we be expected to be in charge. So, you know, we do things a little different.
How do you learn best?
Pardon?
How do you learn best?
I learned best by mistakes.
But if you made a mistake in this, without it, how to do this thing?
Sure. I can learn any situation.
So Mike, you said if I wasn't there, you'd take over. And is it something about me? I mean, you take over because of me, or you take over because that's what you're trained to do?
No, that's because we're trained to do it. If you weren't, I would say, if you weren't there, if there was nobody there, you know, we have to do certain things. But when we get a team together, you know, especially a mixed team, it's a different dynamic.
Well, I've worked with you for a lot of years, so what should have I done different? I trust you. And if you can do it, I know you can do it, and you would have if I wasn't there.
Dr. Ruud, I think we need to time out here. Okay, I don't, that's not what I'm hearing. I think what Mike's trying to say is that What are you trying to say?
I'm waiting for you to tell me what I said.
He's trying to keep his job.
Dr. Root, I think you have a lot of great knowledge, and I just feel like the rest of the team would love to have you share some of that knowledge.
Actually, I think that Dr. Root maybe truly wants to know why you guys are acting differently because he's in the room, and this is the place where it's safe for you to talk about that. So go ahead and tell him why it would be different if he wasn't there.
I agree. I'm not going to fire anybody here, but we already know that she's uncomfortable.
I don't want to be here.
And I accept that. And our medical student, you know, I need to give him more direction. But Mike, you would take over, and I would trust that you would do it. So what could I do differently in this situation? How could I do what you do? What did I, you know, please tell me what I did wrong. I didn't think I was doing anything wrong. Really? Should I have taken the bull by the horns and just said, Mike, I want you to manage the airway. Justin, I want you to do CPR. And Sandy, I want you to do the IV. Get that right now. I'll call and order some labs. I mean, would that have worked?
Sure, that would have been a good plan.
That would have been helpful. So Mike, when was the last time you took ACLS? And Dr. Rubin, when was the last time you took ACLS? Changing up computers more current. Because if it's more current, then maybe he has open suggestions, and since you don't know the changes, if you're open for suggestions.
1998.
There we go.
But I mean, I've been in the ER a lot. But I do trust this guy, so maybe that's a good question, Mike. If we get in a situation like that again, can I call on you to say what should we do next, or would you be the team leader? Can I just pass the buck to you and maybe I'll do the CPR or something?
There's a lot of times where we don't, you know, that somebody's going to be a team lead, but in many of our cases, our team lead also is an active participant because we've got so limited number of people there. So they have to be involved, and maybe that would work.
So you guys, we're doing this for an iPad doc? I mean, you guys are asking a lot of questions of us and wanting to take the time out and stuff. Did I screw up?
No, I think you just maybe a little bit overestimated the other people's roles.
I don't think it's necessary passing the buck to the paramedic. It's, and we do this in our hospital. Hey, doc, here, let's work together. What do you think? And our doctors turn to us and go, what do you think we need to do? And we'll sit there and start hollering out things. Let's try this, try this. Then we go down our agency meeting. And we'll turn to them, what do you think? And then we get a pediatrician that comes in, we're talking, and we're working with the team and utilizing all our knowledge and not just taking one person take charge and give out the orders. It's a group of us conferring with the team leader, giving our suggestions to the team leader and what should be done, and then you have the ultimate decision.
Maybe it's like Justin, just last week when you and I were in the ER and we had the shortness of breath patient, and I thought it was COPD, and you said, well, maybe it's pulmonary embolus. He just came over from Germany on an airplane. And you were right. And Jeremy, I told you, maybe I just saved my life in that one. Maybe I should do some more of that, I guess. Use you guys. So this is good. I'm feeling a little better.
I was just going to say that it was helpful for the patient, and it was nice to be an active participant. Even last week in the ER with the patient.
Yeah, you did great, man. You diagnosed that, and that just went right by me.
Thank you.
Yeah.
Sandy, can you tell us what you thought was really positive that happened? I know you're scared, but what did you?
I don't ever want to go to ER again.
Besides that.
I think I need to take ACLS.
So do you
Positive?
I should
Positive?
probably do it again.
Yeah.
But you know, let's do it together. Maybe it'll be the new year.
Dr. Luke, what could you say something that Sandy did that was really good?
You know, before I even realized that he needed nitro, you were spraying nitro in his mouth. I mean, wow. I mean, that was one of those, I'm glad, thanks for doing that.
I'm a good nurse, I touch my patients.
She followed orders pretty well when something was, she was there, you know, just don't run around the bed so much.
Okay, and I will check about how deep to do compressions, so I think I was a little short on that. Good, yeah.
So do you feel like you would do better if you had the chance to do this again? Do you guys feel like it would go differently?
Definitely.
Okay, well, let's do it.
I'd love to give a chance, because the way Justin and I worked in the ER last week, and Mike, knowing that Mike knows that the protocol is really good, I think we should try it again, and then I'll just kind of take charge and get people going, and let's see how we do.
Good idea, Dr. Ruth.
Good. Good practice.
Okay, so you guys were great, guys, and now we'll come out of character here. Dr. Yearwood's sitting there thinking, that's not Dr. Ruth. That's not Sandy sitting there. I guess we simulated the simulation again because they weren't really here. I really like the way everybody's getting involved. You're asking questions and being on the spot like that, trying to portray what Jamie Rude would have portrayed when he was here, is that kind of tough nut to crack that felt, this is my duty to let them, I'm here to teach them. Let them get involved so they can learn something. So those are the kind of things. It was a little bit difficult, but it wasn't seriously difficult. I doubt you're going to have something like that on every one of your simulations, but I'll bet you come up with some of those once in a while. And you probably know the institution that you're going to go to where this is going to happen, don't you? You probably know some of the people. You've been there before. You get an intercept with them, or you picked up some patients in their ER and you saw the behaviors and stuff. They're good people. They just they need a little help sometimes, and we can really help improve them. So.
I just have a question. We brought this up earlier about how, you know, rural communities, those patients that are coming into this facility is our neighbor, our mom, our dad, our loved one. And say there's a trauma out there. We have 4 people that show up for a code. And so say you're going to be the team leader, and everybody's standing there waiting for this code to come in because communities bring them in and whatever. So you get there and you are completely off guard that that's your dad laying there. I think that maybe we need to, I mean, it would kind of be interesting to kind of switch it up, and you have your team leader who's completely fumbling. Maybe your wife is having a baby, you're going to have a baby soon, and you just are not there. And I think that we need to stress too that it's okay if somebody notices that somebody's not doing their job. It's okay to completely step up and take the ropes and take charge. Like, I think that would be a good thing to kind of work in too.
And suggest that, bring it up and start working through so you can introduce that. You know, we understand something else is going on. Maybe somebody else should. Yeah, I like that. Amy, are we ready for?
We are ready.
Okay.
We are going to take a 15-minute break. Snacks, coffee, water's up there. Meet back here at 2:45 for our final lecture, which will be Dr. Newman this afternoon.
Thanks for your interaction. Thanks for allowing us to kind of ad-lib it and get questioned. I really like how those questions came out. And Deb, I like that time out. You know, something, let's take a time out here. And,
what is this?